my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello and welcome to the latest video interview for the Medicine Journal series. I'm Albert Ferro, I'm the chairman of the editorial board, and I'm delighted to be joined by Professor George Griffin. Welcome, George.
Thank you.
And the reason George is joining me today is because we're going to be talking about infection and infectious disease, and the January, February and March 2026 issues of Medicine are devoted to infections, and George has been overseeing that. So lovely to see you, George, and we'll talk a little bit around infections and what's important in the area, and bring out some of the things that are talked about in the journal, but also some other things which aren't. And I thought maybe the first thing we might just touch on is where the whole specialty of infectious disease has been going in recent years. It's actually changed dramatically in the way that trainee doctors get trained in infectious disease, hasn't it?
Well, absolutely, Albert. And that's a very good way to start off to explain what's happened to the new three issues that you mentioned already. Originally, infection was in what was called fever hospitals clinically. And St. George's, where I was the head of the academic centre and consultant physician there, emerged from that over many years. The fever hospitals used to take in TB, travellers, sailors, and it was totally and utterly restricted entry. No visitors. It was really, really old-fashioned. And over time, of course, infection has become very modernized and is now absolutely cutting edge. It became cutting edge by having specialist units that had proper links with the hospital, did work with other disciplines in the hospital who were needing advice on infection. And more recently, and I'm going to dwell on this a little when I get through to speaking about the issues, there's been a great link between clinical ID, infectious diseases, and laboratory bacteriology and virology. And this has been a huge advance. And this is, as I mentioned, reflected in the three issues. Now there are specialist ID units in many hospitals, and many hospitals now who are appointing new pathologists, for example, will have people who have joint training. And the joint training is the big thing which has happened in the last few years. And this has been an amalgamation between the Royal Colleges, the Pathology College and the College of Physicians. And they've realized that there is a complete crossover between the laboratory work and the clinical work, and both depend on each other. And all of a sudden, this realization really got to work and formed what is called joint training. And this is for physicians and for pathologists. Joint qualifications are required. MRCP is essential. FRC Path is essential. The CST in joint ID and microbiology, as it's now called, is highly sought after. the acceptance rate is between 1 in 5 and 1 in 7 candidates.
Sure.
And many of those candidates will have BScs or PhDs in the area. So it's a long training. Big advantage has been that because all hospitals don't have ID specialist units, but they have lots of microbiologists. If you get a microbiology consultant's post and you've got the joint training, you are a great catch for the hospital, because you can then use both disciplines in the care of patients. There are many more pathology jobs than there are pure ID jobs. So that's a real help to the discipline of clinical ID, linking closely with a formal microbiology.
It's advanced in a big way. It's obviously become a more competitive specialty, from what you say, with the numbers that you quoted in terms of posts per number of applicants. I guess a lot more interesting as well, but harder work, because they have to pass not just the MRCP, but also the FRC Paths. They've got 2 sets of postgraduate examinations they have to do. But nonetheless, it sounds like it's become a lot more competitive and a lot more applicants going into it. Is that fair to say?
It is indeed. And the model originally, of course, was in hematology, which there are now clinical hematology units with joint training. With both the MRCP and hematology clinical training and laboratory training. And that is equally competitive now as a big discipline to get into. Covers many areas as well, of course, like ID, transplantation, malignant disease, nutritional deficiencies. So there are these 2 models now of proper joint postgraduate training.
Excellent. Let's go into some of the topics that are covered in the journal. And I guess one of the important ones, of course, is TB, which has obviously been around for a very long time.
Very much.
But things are changing in the TB world, aren't they?
Well, if I could just follow on first, Albert, now I'll lead through to that. There's a great resurgence of ID as a clinical discipline because units have been formed, and there is now the joint training, as I've mentioned. What has happened then is that the laboratory techniques are absolutely understood by the clinicians, and the pathologists absolutely understand the clinical events that are happening. So there's a really good union there. In terms of TB, of course, this is a notifiable disease, and there has to be containment, particularly, well, of course, with pulmonary tuberculosis, with people coughing. So isolation units are still needed. And in my own hospital, St. George's, we have a 20-bed unit with single rooms isolated with negative pressure. And then joint rooms for people who are recovering and you got rid of the infection until they get better. So this has been a huge advance, actually, in the management of infection in hospitals. And in my own unit, for example, all of the other disciplines call upon advice, particularly surgeons, of course, and also respiratory medicine. So it's a real team effort now, and joint training has facilitated that greatly. Back to your question about tuberculosis, this a lot of people thought had gone away. Of course it hasn't gone away. And it always has to be at the top of our minds in many ways, particularly with immigrant populations, particularly with immunosuppressed patients who might have had TB in the past, and this can light up the TB again. The other big thing, and this is where the joint training that I mentioned comes in, is that we're now encountering moderate to high rates of antimicrobial resistance. And the joint training has stressed the use of the modern microbiology techniques. So the old petri dishes and broth bottles are used, but they're getting to be obsolete now. And it's PCR technology, it's equipment such as something called MALDI-TOF, where you can get much more rapid diagnosis. And in suspected sepsis, of course, which has always been a difficult problem, and we always hear stories of patients who've not received antibiotics and sepsis has been missed. We're beginning to get on top of that with these new techniques. So this link of laboratory technology and expert, very good clinical work is a match made in heaven, in my opinion, and that's reflected very much in the new issues.
I guess it makes sense, doesn't it, to join the diagnostic and the clinical aspects, and it's, I guess, surprising that it's not happened until more recently, but it seems a very logical marriage there.
But as you said, it does increase the length of training.
Yeah.
And because of this a selection rate, the joint trainees, like in hematology, are attracting very, very good candidates, often with PhDs and BScs, medical degree, and the two professional qualifications. So we're talking of very, very good units.
Yeah, no, certainly. So you mentioned antimicrobial resistance, and that's obviously a very big issue. You mentioned it in the context of TB,
Yes.
and how that's increasing. And I guess it's, for some years now, it's been increasingly recognised how that's not just the case for TB, but it's a problem for all our infections. And so I guess rapid diagnosis is going to be quite important, isn't it?
Oh, it's crucial. And you're absolutely right, Albert. I mean, some of the gram-negative organisms, Pseudomonas, for example, and some of the E. coli are highly resistant now. And if you have a septicemia with that, with those organisms, it can be very, very difficult. But with the modern techniques, you can begin to get a quick handle on the antibiotics, which can be used and used in combination as well, of course.
And you mentioned sepsis as well, which is obviously a really important issue and often underdiagnosed or diagnosed too late, of course. So early diagnosis of sepsis can be, is life-saving, really, isn't it?
That will be another aspect of the joint training, which is beginning to take hold. Jointly trained trainees will be going down to casualty to see febrile patients who are severely ill with no obvious reason, and samples will be taken. Cytokine measurements will be made in blood very quickly, and the appropriate treatment can start. And every week we're seeing, of course, in the newspapers, sepsis missed in patient who dies. It is a difficult diagnosis that people are getting aware of now, and the techniques are available for rapid choice of antibiotics and treatment.
Maybe turning to something that I know you've been very much involved with, and that is that was exemplified by COVID, of course, a new virus that came along and caused terrible problems around the world, and you were obviously very involved with that. I guess we could talk about that for ages, but maybe we don't need to sort of dwell on it. But I guess there is always the issue about new viruses coming along, recognizing those, intervening early. What would you think are the lessons that we have learned from the pandemic, from the COVID pandemic, and how can we recognize new viruses early and intervene earlier, intervene in a different way, do you think?
Well, the first thing is there must be absolutely first-class surveillance systems, and we have those in the UK, to see just what is happening in the UK. But as important, in conjunction with organisations like the World Health Organization, seeing what's happening in distant countries. And that's very important for travel. very important for getting rapid diagnostic tests organized. And it's an international collaboration. So, for example, in influenza, the epidemic, if that's the right word, if the epidemic starts in the southern hemisphere, usually, and then travels up to Europe and the West, and you can see if there's good contact between countries and WHO, this can be tracked very well. So I would put surveillance very, very high on epidemics and pandemics. And then, of course, there has to be a national response. And you know how difficult that was in the UK to get things organised and then eventually to have to go to lockdown.
Yes.
The big advance, of course, and this joins up pathology with immunology and clinical medicine, is that messenger RNA vaccines have revolutionized getting a good immune status, particularly in old people who were allegedly not going to respond to viruses. But we know now that older people have a very good immune response to mRNA vaccines. And that's what happened in COVID, of course. Eventually, the research switched from being the surface antigens to being messenger RNA vaccines, and then messenger RNA vaccines with an adjuvant given intramuscularly. So that's a really good example of the fusion of first-class laboratory techniques, first-class surveillance, and using that to join together with immunology and clinical medicine.
Yeah, okay, sure. And as you say, the mRNA vaccines certainly emerged as the way to go. And do you think that is the way of vaccines in the future? Is that because I know there's been a lot of disquiet in certain quarters about the possibility of genetic alterations and that sort of thing. But what, do you think that mRNA vaccines are really the way to go in the future?
Well, there are certain viruses which become epidemic, of course, because you can get the sequence of those viruses, and from getting that to having a vaccine takes a maximum of 3 months. In the old days, you would have to wait a couple of years to get there. So the advent of mRNA vaccines is a fantastic help for a sudden thing like COVID, for example. The vaccines have to be produced, and that can be done actually very rapidly as well by industry. I doubt if the well-established vaccines that we have, like tetanus, diphtheria, will be replaced by mRNA vaccines. We know they work well. They're cheap. They're produced in massive quantities. But for the viral, rapidly exploding pandemics, mRNA has revolutionized the system.
I guess especially for viruses that mutate rapidly and so on.
Absolutely. You can always be ahead of the game by the rapidity of being able to produce these agents.
George, thank you very much. It's been a fascinating discussion. I think the whole field of infection is undergoing a transformation at the moment, both in terms of the training aspects and the marrying of the laboratory and the clinical aspects that we talked about, but also in terms of the techniques that are becoming available for diagnosis as well. So, George, thank you very much for talking with me today.
If I could say something else, is the 3 issues of infection for medicine have reflected exactly what we've been saying. The 2 editors, Angela Houston and Amber Arnold, are both jointly trained and have CSTs, as I mentioned earlier on. And one of the issues reflects the modern techniques for rapidity of diagnosis. And then many of the other things have been altered and renewed. Antimicrobial resistance, you mentioned, has been included in most of the infections that are described in medicine. So the new edition, the 3 issues, is very contemporary and will test test time actually for the future. Be great for both joint trainees and single trainees, which of course still happen, but particularly for the joint trainees in the future.
So that's a definite recommendation to read the 3 issues.
Oh yes, I think it's an excellent rejuvenation, let's say, of the infection series. I'm very, very pleased, and Amber and Angela have done a great job on this.
I agree. Thank you ever so much, George. Thank you.